I'm a neurosurgeon. I'm a neurosurgeon in training and trained at the University of Utah. Then I did an orthopedic spine fellowship at Rothman Orthopaedics in Thomas Jefferson. So that was kind of my connection to Rothman when they expanded down here into Florida. Before joining the practice in Florida, I spent 16 years in practice at the University of Illinois College of Medicine in Peoria, Illinois, where I was department head of neurosurgery and the fellowship director for spinal surgery. And me and my family were just ready for a move to Florida. Very excited to join Rothman and what Rothman brings in terms of really superb subspecialty care. So what do? I evaluate and treat patients with various spinal conditions, and rheumatoid arthritis is very, very small fraction of these patients, but a very complex group of patients, very, very challenging in comparison to a lot of the other disease processes that we have in spinal surgery. And I try to help evaluate whether surgery is a good option for treatment. So many patients, when they come to our practice with typical degenerative issues, spinal arthritis, which most of us are going to have some spinal arthritis. Most patients are going to start out with maybe one of our non-operative doctors or physician assistants that work closely with the non-operative doctors and the surgeons, and kind of try some non-operative treatments initially before seeing someone like myself to discuss the option of surgery. So I treat the entire spine from the neck down to the lumbar spine. Radiculopathy is probably the most common condition that we treat, and that's just a medical term that means pinched nerve and an irritated nerve, either in the neck or the lower back, most commonly. Myopathy, which is a damaged spinal cord, and with someone with rheumatoid arthritis, we are seeing patients with myopathy. So rheumatoid has a significant risk for a spinal cord issue. I really enjoy spinal oncology, treating patients with cancers that have spread to their spine. It can be very gratifying. We can really help preserve their patient's ability to walk and really help them out with pain and their quality of life. And then I also do a lot of scoliosis surgeries, mostly adult scoliosis surgery. So these are older patients that develop scoliosis as a result of arthritis that forms later in life. Or sometimes they have an idiopathic scoliosis, a scoliosis that occurred during adolescence that progresses during adult life. So in terms of rheumatoid arthritis is an autoimmune condition. In other words, your body's immune system, your own immune system, is attacking your body and certain parts of your body. With rheumatoid arthritis, it's a polyarthritic disturbance of peripheral joints, any joint that has a synovial lining. So the synovial lining is basically a lubricating lining for most of the joints that we have in our body. And rheumatoid arthritis attacks that synovial lining. Typically, it's going to produce symmetric symptoms. So if you have arthritis in your hands, usually it's not on one hand, it's in both hands. And then there's also a number of systemic issues with that, which we'll review further later on in this presentation. Rheumatoid arthritis affects about 1% of the population worldwide. Onset is usually 40 to 70. There is a juvenile form that's more rare, juvenile rheumatoid arthritis. There is a propensity for females, 3 to 1, but in my practice as a spine surgeon, oftentimes we're seeing more males because males have a greater risk for cervical spine involvement for some reason. So in terms of, what is the cause of rheumatoid arthritis? That's, a really big question, and it's truly multifactorial. There's probably some genetic predisposition in these patients. So there's something in this patient's genetics, and then they're exposed to some environmental factors. Environmental factors have included smoking, silicone exposure, certain air pollutants, diet, infection history, and then periodontal disease. And these factors, along with the patient's genetic conditions, kind of sets off the immune system to attack the synovial joints. So this picture basically shows, you have genetic factors. Possible you could have had a joint infection at some point that kind of sets off triggers, and then environmental factors that produce what we call self-antigens. So these are markers within our immune system, markers in our body. So for instance, a virus or bacteria will express antigens that normally our immune system will attack. Well, here we have these self-antigens, and normally our immune system is just chilled out, relaxed, no big deal. These antigens are there. Well, in rheumatoid, for whatever reason, these antigens are converted, what we call citrullination, um, and then these modified antigens get deposited and kind of trigger the immune system within the synovial joints and produces a migration of immune cells into the synovium and plasma cells, which produce antibodies. So rheumatoid factor is an antibody, an ACPA, anti-citrullinated peptide antibody is another antibody that can be measured in rheumatoid arthritis to help us make the diagnosis. So this on the left is a normal synovial joint. So you have a lining that produces a fluid that helps lubricate our joints. In early rheumatoid arthritis, these synoviocytes accumulate as a result of the attraction of these antibodies and kind of trigger our immune system, and it kind of goes wild, and then it produces inflammatory mediaries that can produce inflammation and pain, destroy the joints, destroy the surface of the joints, and also destroy bone. So again, a complex picture. So our synovium and our synovial fluid has immune cells which come into the both of those areas, both the synovium and the synovial fluid, which produce a lot more inflammation, which produces vascularity. So vascularity can be bad in terms of producing more inflammation. It's kind of a self-propagating process that can result in angiogenesis, which is production of new blood vessels. Normally, we think of blood vessels as good, but in certain situations where there's overstimulation, over anti-inflammation, the angiogenesis produces, greater inflammation and more problems. The disease kind of propagates on itself or snowballs. So in 1997, the diagnosis or criteria for rheumatoid arthritis was determined based on these seven factors. Morning stiffness, arthritis in 3 or more joints, arthritis particularly in the hand joints, symmetric arthritis, rheumatoid nodules, which I'll show a picture of here shortly, positive rheumatoid factor. So back in the 80s, we could measure rheumatoid factor, and then radiographic changes, destruction of the joint on x-rays. So we needed 4 of 7 of these factors to make the diagnosis of rheumatoid arthritis. So someone early on in the disease process, it could be very challenging based on this criteria, determine if they truly had rheumatoid arthritis or not, and therefore there could be delays in treatment. So here's a picture showing some rheumatoid nodules. So rheumatoid nodules are basically these inflammatory fibrous tissues that get deposited in the subcutaneous tissues, usually around joints. So we see them around the elbow, we can see them on the hand and wrist, and we can see them around the fingers, as you can appreciate here. So in 2010, the guidelines, the ACR, the American College of Rheumatology, along with basically the same group from Europe, came up with a new scoring system to help us diagnose rheumatoid arthritis earlier in the disease course. And here's what we're looking at here, the joint involvement, how many joints are involved, which joints are involved. You get a score based on that. The serology, in other words, the blood work, checking your serum. Is it positive for rheumatoid factor, and is it positive for ACPA? And then there's a high positive and a low positive. Acute phase reaction. So these are inflammatory mediators that we can measure in the bloodstream. So what we call CRP and ESR are those elevated or normal, indicating greater inflammation, and then duration of symptoms. And someone with a score greater than 6, we think this is definitely going to be rheumatoid arthritis. So with this scoring system, we feel that it's easier to diagnose rheumatoid arthritis earlier in the disease course, and then now, provide treatments to try to modify the disease course. So rheumatoid arthritis, so I'm a spine surgeon, and so I'm not just seeing anyone with rheumatoid arthritis. Usually I'm seeing patients with spinal involvement. And rheumatoid arthritis has a predilection for the cervical spine. So early on disease course in untreated rheumatoid arthritis, the cervical spine can be involved. And if this is not treated early in disease course, it can really result in some significant issues with destruction, particularly in the upper cervical spine, what we call the cranial cervical junction. And it can lead to conditions where the spinal cord is compressed and the brainstem, the base of the brain, is compressed from that arthritis. And that can result in damage in those neural structures and tissues and result in significant disability for patients. So rheumatoid arthritis likes the synovial joint. So in the cervical spine, there's 32 synovial joints which could be affected. And then the joint between the first and second vertebrae, what we call the atlantoaxial joints, there's movement there. I've seen some studies that show there's about 650 movements every hour at our atlantoaxial articulation joints. So this is one of the more active joints in our body, and as a result, with rheumatoid arthritis, this may be more prone to wearing out. We see three patterns of instability with rheumatoid arthritis in the cervical spine, what we call atlantoaxial subluxation. So atlantal and axial are the first and second vertebrae. So C1 is the atlas, and then C2 is the axis. So the first vertebrae is our ring, and the second vertebrae has a peg that rotates around it. We call that peg the odontoid process. So atlantoaxial, so subluxation means abnormal movement or slippage. So we see that the joint, the connections between the first and second vertebrae with this condition are wearing out and becoming loose. Atlantoaxial impaction. So this is kind of a progression from the subluxation. As things start getting loose, then the joints on the side, what we call the lateral masses, those joints can degrade and collapse. And as a result, that peg that I was describing, the dens, can migrate up through the base of the skull. And the base of the skull, usually you just have your spinal cord exiting through the base of the skull. Well, the dens goes up there, it can cause pressure on your spinal cord. It can also migrate up and cause pressure on your brain stem. And then the third condition is subaxial subluxation. So this is subaxial means anything below the second cervical vertebrae. So we can see slippages occur. More commonly, we're seeing the first two variants. I'll show you some more information on all three of these. So in terms of atlantoaxial subluxation, so we're talking about, hopefully you guys can see my arrow on my computer, my cursor. We're talking about the joints here between the first and second vertebrae. So here's the peg. Okay, here's the back of the ring and the front of the ring. So there's a weakness that develops between the first and second vertebrae in terms of holding that ring up against the odontoid up against that anterior ring. As a result, inflammatory tissue can deposit behind the odontoid process. The ring can slip forward, and as a result, can pinch the spinal cord. So in this patient, we're seeing pinching of the spinal cord here. This space, so here's the front of the ring, it's slipped forward. So normally the space is not as great as it is. So this can result in a number of conditions from neck pain. It can cause what we call occipital neuralgia. The second cervical nerve is leaving between those two vertebrae, and that can produce pain in the back of the scalp. And then it can produce a pinched spinal cord and what we call myopathy, which is you gradually damage your spinal cord to the point where some people will lose their ability to walk. Usually it starts out with some numbness in the hands and coordination problems. So this is the most common pattern of cervical instability. It can be observed in 49% of patients that haven't been treated with modern medications. Fortunately, with modern medications, we have modified the disease course and we don't see these changes nearly as frequently. So here is an image showing the back, the connections between C1 2. So this is the transverse ligament. This is the peg. It sits in front of it. So that ring is in front of that. So this kind of holds that odontoid process up against the ring. And this ligament can degrade as a result of the inflammation associated with rheumatoid arthritis and develop instability there. So here's a close-up picture again. We're seeing pannus. This is inflammatory tissue developed behind the odontoid, and we see that. So here's a normal diameter of the spinal cord. We see the spinal cord is thinned out here, compressed, and the posterior ring has slipped forward. So that's resulting in compression on the spinal cord. Here is an image showing impaction. So again, the odontoid is separated from the ring of C1, and it's migrating. This is the base of the skull. So it's migrating up into what we call the foramen magnum, which is the base of the skull, where there's some very important structures, your spinal cord and the base of your brain. So that can cause damage in those structures. Here is an image kind of showing how that occurs. So this is normal. As we start getting degeneration, this is the ring of C1. This is C2. This is the foramen magnum here. As everything deteriorates between C1 and C2, it collapses. And then this peg, the odontoid process, migrates up into the base of the skull. So here's, let's go back. So here's an MRI. Peg has gone up through the base of the skull. So now it's pinching the base of the brain and severely pinching and compressing the spinal cord right here. And then here is an image. So this normally is an open space for the spinal cord. Instead, you have the odontoids process sitting within that foramen magnum. And now this is only space for the spinal cord as it's exiting the skull. Another cadaveric picture. So here we see this is the front of the foramen magnum. This is the back. So normally this odontoid process would sit down here. Instead, it's migrated up, and you can see how it occupies most of that space and would cause compression. This is the only space left for the spinal cord. And then subaxial subluxation. So again, below C2, we see arthritis form in the facet joints in the back that weakens those. And as a result, these vertebrae can slip forward. I'm actually, with modern medications, I'm seeing less cranial cervical problems, and I'm seeing more commonly subaxial subluxation later in life in patients with rheumatoid. Again, here's an MRI kind of showing that, where you can see the slippage of the vertebrae occupies the space for the spinal cord and causes pressure on the spinal cord and damages the spinal cord, what we call myelopathy. So atlantoaxial subluxation can lead to impaction, where the odontoid goes up through the base of the skull. And then that can lead to more instability, more impaction into the base of the skull. And then ultimately that can lead to subaxial subluxation. So it's kind of a cascade of events. So in terms of the clinical symptoms, cervical instability is frequently asymptomatic. So some patients might not even appreciate that the joints are being destroyed and the joints at the base of their skull are loose. Neck pain is probably the most common complaint. Suboccipital pain, the back of your scalp. And that could become from the second cervical nerve getting compressed as it's leaving the spine, from the degeneration and instability causing compression on that nerve root. Symptoms typically are mechanical, so they increase when we first get up in the morning. We see some more stiffness. Sometimes as you get up and move around, that can improve. The pain can improve. Myelopathic, that means that the spinal cord is being damaged from the compression. Vertebral basilar insufficiency. So the vertebral basilar is the brainstem. So there's a number of important nerves leaving the brainstem that are involved with the inner part of the ear, which can cause vertigo and tinnitus, as well as swallowing problems. I would say I've seen a number of patients with basilar invagination from rheumatoid that have significant swallowing dysfunction from brainstem compression. It can cause sleep apnea. I think there is a small risk for sudden death because of the brainstem getting compressed. So there's parts of the brainstem that are important to stimulate us to breathe. And if that area is compressed, you could possibly, suddenly pass away in the night and lose your response to breathe. Neurological findings usually appear later in the disease course, and sometimes it's very challenging to figure out if a patient's having spinal cord compression and neurological issues, or is it they're losing function because they're peripheral arthritis. So we see patients that have advanced rheumatoid arthritis and oftentimes their hands are just destroyed. The joints in their hands, unfortunately, are destroyed. So they've lost a lot of function in their hands. And when we're trying to figure out if a patient has spinal cord compression, we're oftentimes talking about dexterity in their hands. Well, they've lost their dexterity from the peripheral joints being destroyed in their hands. So sometimes it's a challenge to figure out, are they having issues from the spinal cord, or is there systemic rheumatoid arthritis causing the problems? So if we have a patient that was walking and then suddenly, is wheelchair bound, that raises a high suspicion there's a spinal cord problem. But oftentimes there's a delay in diagnosis. Like I said, it's hard to tell. Is it the rheumatoid arthritis destroying the peripheral joints, destroying the hands, the hip joints, the knees, that's resulting in the trouble walking, or is it the problem with the spinal cord being compressed and damaged? So radiographically, we used to do a lot of screening for patients with rheumatoid arthritis. There used to be protocols before modern medical treatment for rheumatoid, where most rheumatoid patients would get screened before surgical procedures to see if there's instability in their cervical spine, because there's risk when you undergo general anesthesia. Anesthesiologist has you asleep and they're moving your neck, and it's possible they can create damage in your spinal cord. Now, with modern medications, we don't see the degree of instability in most patients with rheumatoid, so screening has become much less prominent. Screening is usually done with just plain x-rays in the office, where we'll take pictures both from the front and the side, as well as asking a patient to move their head forward and back. And we can assess and see if the bones stay in normal alignment, or if there's slippages that develop, and what we're concerned about is instability and possible pinching of the spinal cord. So ADI, this is a measurement, the lanal dental interval. So the lanal is the front. This is the ring of the atlas. So normally this interval is pretty small. It's usually 2 to 3 millimeters. In rheumatoid patients, it can get much wider as the ligaments that attach those two bones get destroyed. That can result in loosening of those joints. They can sublux, instability, and obviously that can result in pinching of the spinal cord. So we used to commonly look at the ADI in patients with screening radiographs before they would have surgeries. But we really found that there was no correlation with neurological injury, although we definitely got more worried as this degree of subluxation increased. The PADI, so this is the posterior lanal dental interval. This is probably the more important measure. This is the space for the spinal cord. So this is from the back of the odontoid process of C2 to the posterior ring of C1. So that space is what is left for the spinal cord. So if that space gets narrowed below 14 millimeters, the spinal cord is about 14 millimeters. That means the spinal cord is being compressed. MRI scan is probably the mainstay if we're concerned about rheumatoid arthritis and neural tissues being compressed. So we're going to do an MRI scan we can assess the ADI. An MRI scan, though, it's a static image, so we can't assess stability on an MRI. So we're doing this when someone's typically lying supine. There are stand-up MRIs and sit-up MRIs nowadays, but in general, we're looking at a static image. It's not assessing stability, but we can still see if there is compression on the spinal cord. Is there a pannus inflammatory tissue that's resulting in problems and compression on the spinal cord? And then the cervical medullary angle. So as the odontoid travels up and instability develops between the occiput, the base of the skull, the first and second vertebrae, there can be angulation and kinking of the brainstem. So we're looking at the cervical medullary angle. That's an angle that helps us kind of predict whether the patient's going to have neurological issues from brainstem compression. In terms of our goals for treatment, our goal is to reverse existing neurological deficits. So if the patient has lost their ability to walk recently from spinal cord compression, our goal is to relieve that spinal cord compression and try to have a return in some function. So patients with myopathy, modern studies. So we did a study probably, I'm getting older, probably 15 to 20 years ago. Back when I was in training 25 years ago, we would describe this as surgery in general for patients with myopathy is preventative, prevents you from getting worse. Modern studies have shown that patients with myopathy about 80% will see improvement once we get the spinal cord decompressed and provide stability to the spine so the spinal cord is not being traumatized. 80% of patients will see some improvement, but I usually tell those patients that they're not going to get back to normal where they were 2 and 3 years ago. They're going to have some improvement. Hopefully, if they're non-ambulatory, regain their ability to walk. We're trying to prevent irreversible neurological damage, and then, of course, improve pain and function. And then in rheumatoid patients, these are high-risk patients. We're trying to avoid unnecessary surgery. So these surgeries are complex. There's a lot of factors that go into rheumatoid arthritis, and one surgery can turn into multiple surgeries. Oftentimes, these surgeries just aren't up one spot because the arthritis, like I said, there's 32 synovial joints in your cervical spine, and a lot of these joints can be involved. So you can fix one area and another area can go bad. So we have to consider that and balance that when we're doing these surgeries. So oftentimes we're doing multi-level surgeries to provide stability to the spine. Supportive care can help with symptom relief, but doesn't alter the course of rheumatoid. So patient education, lifestyle modification, physical therapy to try to help with pain and restore function as possible. Cervical collars can provide some stability. So if a patient's not an appropriate candidate for surgery, surgery is just too high of risk from heart disease or other things, a cervical collar might provide some stability so the spinal cord isn't constantly being traumatized and leading to further damage. And then pain injections. We have a number of providers that can provide pain injections to relieve inflammation and possibly help with some forms of nerve pain. In terms of the medical management of rheumatoid arthritis, so back when I was in training, it was pretty much NSAIDs and steroids, corticosteroids. And I was very fortunate to train with one of the world's leader in treatment of rheumatoid conditions at the cranial cervical junction. That was Ron Applebaum. And we were doing 1 or 2 surgeries on a rheumatoid patient almost every week. Nowadays, probably in a very busy practice. I was the busiest surgeon in Illinois for about 16 years, and I would only see probably 4 or 5 rheumatoid cases a year that needed surgery. So with modern medications, we've substantially improved this disease course. So the older medications, NSAIDs, they reduce inflammation, they can help with pain. Corticosteroids kind of calm down the immune system, have a lot of side effects. They can help with pain, but do not alter the disease course long term. Now we have a ton of different options for patients, what we call disease-modifying anti-rheumatic drugs, DMARDs. And oftentimes it's a combination therapies that we're looking at to try to control the disease and improve quality of life for these patients. So here's a list of DMARDs. So I am not a rheumatologist. I do not prescribe these medications, and I can't really speak to these medications other than saying they work because, like I said, I used to treat a lot of rheumatoid patients. And nowadays we simply don't see as many with severe spinal disease and spinal problems because of these very good medications that modify the immune system. So we have synthetic DMARDs, and then we have biological DMARDs, and I'm not going to go too much into that. The biologics, are small. They're kind of they can be antibodies that are made to attack one area of our immune cascade and try to shut down that portion of the immune system in the cascade against rheumatoid arthritis. So if you have rheumatoid, it's very important that you establish yourself with a good rheumatologist and have, explore all of these options for treatment to try to prevent this disease from progressing. Risk factors for progression in terms of the cervical spine, particularly in patients that are untreated. Males have a greater risk. So there's seropositive and seronegative rheumatoid. So you can have rheumatoid arthritis but not have rheumatoid factor. But if you have rheumatoid factor, then you have a greater likelihood for developing issues with the cervical spine. Elevated CRP, so this is C-reactive protein. This is one of those inflammatory markers that we can check with blood work. Presence of subcutaneous nodules that I showed, the rheumatoid nodules. Advanced peripheral joint involvement, the longer duration, And then my experience is that patients on prolonged steroid use, oftentimes we see a greater involvement with the spine. So if a patient can avoid being on steroids, rely on some of these other medications, typically they're going to do better long term. Surgical indications, we kind of discussed this a little bit earlier. Progressive neurological deficit. So is the spinal cord being damaged? Are we convinced that that's the problem that's causing the patient to deteriorate, lose their ability to walk, lose function in their hands? If that's the case, then that's a very strong indication for surgery. Chronic neck pain, I would say that most situations I'm going to try to avoid doing surgery for chronic neck pain, because I can never guarantee to a patient that I'm going to cure their neck pain with any surgery that I perform. And like I said, these are high risk surgeries. It's not like we just go in there and fix one joint. These usually have multi-joint involvement and very complex, higher risk surgeries. And we really want to do it to preserve neurological function, which is what we're good at as surgeons, whereas curing neck pain is probably not our best outcome. Like I said, this is one of the more challenging problems in spine surgery because of patients' medical comorbidities, the complexity of these joints being destroyed. There's deformity. So this PEG, the odontoid process, goes up through the base of the skull. We have maneuvers to try to pull that back down and then stabilize things. So these, on a scale of 1 to 10, these are 9 and 10s in terms of surgical complexity. And it's key here for my practice. I really would prefer just to try to treat patients that are having issues with neurological disorders and spinal cord compression, because that's going to produce the best outcome. I don't want to operate on everyone for neck pain because, as an honest surgeon, I can't cure neck pain in a lot of individuals. So we're trying to do it for port compression. So here's a couple images of patients that have had surgery for port compression. So here is the base of the skull. So their second vertebrae is almost completely, traversed up into the inside of the skull. So it normally lies below the skull. It's causing compression here on the brainstem and the spinal cord. So we put a patient in traction to try to get that odontoid process to come down. And most of the time we can reduce that. And then we remove the back of the skull. We can remove the back of the first cervical and second cervical bone called the lamina to create room for the spinal cord. And then we're looking at stabilization procedures. Sometimes from the base of the skull down multiple vertebrae can leave a patient with significant stiffness as a result. Another patient, they have a number of different problems from that odontoid process traveling up into the base of the skull, and then pinching of the spinal cord between the second and third cervical vertebrae. Looks like they've had a prior fusion procedure down here. All these vertebrae have grown together. So one surgery can result in arthritis forming in different areas and lead to other problems. And sorry. Surgically challenging because of the complexity of what's happened to the spine, and then the systemic comorbidities. They're on immunosuppressive medications, and they can have other issues with malnutrition, osteoporosis from being on steroids, skin lesion, which can increase our risk for infections. Corticosteroid use increases our risk for infections as well as causes osteoporosis. And then they can have a challenging airway, either from the brainstem being compressed or the abnormalities at the base of the skull make it very hard to get the breathing tube in and remove it safely. So we have to be very cautious with that. And then systemically, patients with rheumatoid can have issues. Rheumatoid can result in inflammation, which can lead to strokes. They oftentimes have issues with sleep, can lead to depression, anxiety. Inflammation can cause changes in the eyes. They have inflammatory changes. Nodules can occur in the lungs. Heart disease, again, from the inflammation can result in atherosclerosis, vasculitis. So a lot of diabetes. So a lot of these patients are very sick and very complex to treat. It really takes a good multidisciplinary team. A lot of these patients will be in the ICU at least for a few days after surgery, just to watch systemically over all of these other issues and possible complications that could occur. So high rate of complications. So, in conclusion, historically, cervical spine stability develops in most rheumatoid arthritis patients very early in the disease course. I think in medicine, we've become much better at diagnosing rheumatoid arthritis earlier in the disease course. And now, fortunately, we have a lot of medications that we can use that will alter the disease course and prevent progression of rheumatoid arthritis. Um, so I'd encourage people to see the rheumatologist and get treatment if you have rheumatoid arthritis. I'd like to thank everyone for their attention, and I'd be happy to answer any questions you might have. See one thing in the chat. Let me see if I can pull it up. Oh, that's Melba saying, please type your questions. Yeah, so if anyone has any questions, if you want to just put a question into the chat, I'd be more than happy to answer them. Otherwise, if you don't have any questions, I appreciate your attention. We'll just stay on here another minute or two and see if any questions pop up.
I see one that popped up on the Q&A, doctor.
Okay, let me see if I can pull that up. How about the use of IF units? I will have to admit, I am not familiar with what IF units are. Interferential currents. Yeah, I do not have any experience with that, other than I kind of know that low dosage currents can control some forms of cancers, and I'm sure that it could also modify our immune system. So it's something I would say it's not a conventional treatment for rheumatoid, but and I don't have any experience with it. If someone's coming in with spinal cord compression, they're probably beyond a treatment like that. Whereas if you're suffering with maybe neck pain, I would definitely consider, even non-conventional treatments like IF, and anything to help with your pain. Okay, thank you for your attention. Yeah, everyone have a good night.
Thank you, everyone, for attending, and have a good evening. If you have any further questions, please feel free to reach out. I will go ahead and type in my contact information. Thank you, Dr. Fassett.
Thank you.